I'm going to introduce Cat Chatfield. Cat.
Okay, so I think from large-scale global education programs to something rather more small-scale and local, but hopefully with some interesting lessons as well. So my name's Cat Chatfield. I was until last summer a trainee GP, so family physician in the UK, training in London, and I had the opportunity to do a leadership fellowship in my final year, which I spent at something called the Deanery, which is the body that provides postgraduate medical education in London. So I'm just going to talk to you a bit about context, certainly not endorsing Stephen Covey. He probably read his quite irritating book, 7 Habits of Highly Successful People, but he does say, and I think we all find in our everyday lives, that our priorities are a function of our context. So I'll just give you a little bit of context about London and where we are last year. So we think, and I'm happy to be wrong, that London is probably the biggest training centre for general practice globally. We have 1,300 trainees at any time. Training, unlike secondary care training, is not based around big organisations, but it's based in kind of geographically linked, loose groups of practices. So the basic training unit is very small, a small practice, which might have 2,000 patients, might have 20,000 patients, but small teams. General practice trainees in London rotate through different training locales, and then across London they're grouped into about 30 different schemes. There's about 100 directors of those schemes, and then about 700 trainers. So it's sort of quite a big scale project. In London particularly, we had feedback from our regulator, the General Medical Council. They said to us, your trainees are saying they're not getting enough leadership and management, so what are you going to do about it? So that was the first challenge. The second challenge, obviously, this should be the first challenge. The first challenge was the categorical imperative to improve care. So obviously that's number one, the key mission. But the practical challenges, GMC, the Royal College of General Practitioners updated their curriculum. They said that all trainees should do leadership and management and safety improvement. We also had the introduction of 5-yearly revalidation in the UK, where all practitioners across all specialties have to demonstrate quality improvement activity. So there's a lot of drivers that we're saying to the Deanery, what are you going to do to embed this into training? So I'm going to talk a bit about what we did in London, but I don't want you to feel London is the only thing going on in the UK. So I'm going to talk a bit about what's going on elsewhere. In London, Oxford and Wessex, they have been running improvement fellowships for quite a long time. So approximately 10 trainees a year in those locations are going through. So 30 trainees a year out of thousands, about 3,000 GP trainees nationally per cohort is not a big impact. Leeds have been running workshops on patient safety and clinical decision making, but no experiential learning. And East Midlands are in the middle of doing a big planning review, but not quite into the action yet. Oxford in 2011 and 2012 were also trialling a quality improvement scheme, which was a centralised scheme in their deanery for GPs in their last year of training, and they ran 3 centralised workshops over a year. So that was a really successful model. And there's lots and lots of initiatives aimed at other trainee groups, which I think we'll hear some more about, things for F1s, F2s, students, etc., etc. So what did we do? Well, I suppose I want to talk a bit about our vision rather than our aims, I suppose. Our vision was brought together with the GP school saying, we think we should do this, we've got no money. Money's already been mentioned. So a group of the 10 GP fellows got together and thought, well, how can we do this? How can we start sharing some of the learning that we select few are getting? And I think we wrote down what we wanted to do, and I'm just going to read it out to you. We want to share our learning and our privilege. We want to create cultural and attitudinal change amongst fellow trainees. We want to reframe quality and safety as integral professional values. We want trainees to start viewing themselves as leaders, even without formal leadership roles, and give them permission to take responsibility for changing the system they work in. We want them to start to see healthcare as a process and a system. We want them to avoid defeatism. We don't want them to be cynical and frustrated with what they see around them. So we want to give them strategies to channel their frustration into action. So they were quite lofty aims and visions. And what we decided to do was to go around to offer to visit all the schemes and give them workshops based on our experiences. The benefits of visiting the schemes were that it was well integrated into the current educational structure. They all have weekly half-day workshops that we could go into. You cover all 3-year groups together. They have joint learning in that space, so you would cover hopefully most of the 1,300 at one time. And basically it was something that was easy to action and put into place. So we went round. We ended up visiting about 70% of the schemes invited us. Some of them wanted us for 2014, and some of them just didn't want us at all. They didn't think it was important. And we had some really good feedback from the trainees. They really liked the work we did with them on leadership. They found that having peer-to-peer learning was really powerful. They saw that we were the same as them, but we'd gone and done big-scale projects, big-scale change. We were sort of changing the way we ran our careers and the way we saw ourselves as professionals, and a lot of them found that quite inspiring. They liked the role modelling, and they found it a good way to be introduced to concepts. Unsurprisingly, what they didn't find was it was a really good way of getting into quality improvement, because I think, as we've heard from Jessica already, talking about quality improvement in the abstract, it doesn't feel very relevant. And it was zero cost. So lessons learned. Workshops are not very effective to teach QI methodology, but they are good for raising awareness. What we then did as part of that was change the requirements for trainees in London that they had to do a quality improvement project as part of their revalidation to pass their year. Obviously that was a very hard driver, and that suddenly got trainees a lot more interested. In terms of how we could have supported them further, we would have really liked to have run the kind of practicum that Jessica's talking about, with a supported experiential project with mentoring, and we know that's been effective elsewhere. The Southwest Foundation programme, Northwest programme, junior doctors in London doing their own programme through DAPS, and a paediatric programme at Great Ormond Street. So that would be the ideal. I think one of the challenges for general practice particularly is the structure of the training, having people very spread out through lots of locales, and educators having lots of autonomy. So lots of the programme directors were able to say to us, we don't think this is important, we're not interested. They ran their own programmes. Some of them are very innovative, some of them have been running the same programme for 20 years and trying to shoehorn the curricula into it. So I think the scale of London also made it challenging. Oxford were able to offer sessions to all their trainees at once. I don't think trying to do a workshop on QI for 1,300 trainees would have been very effective either. So, what next? I think the future direction, which is something that we always thought would be a key theme, is to develop the faculty, to really target the trainers and the programme directors and show them why this is so important for both professional development of their trainees, for education, but also for the future of our healthcare system. And I think I don't need to talk about that because we all believe in that. We need to get those groups to incorporate into their teaching, and we're hoping that having bottom-up change from the trainees, they should be going to their trainers and saying, look, I have to do this, how are you going to support me to do it? And we are trying to provide resources for the trainers so that they can support their trainees with online resources, and we have been round to a lot of the trainers' workshops now as well. I think we'll just keep reiterating the message centrally and saying we think this is really important. We'll offer them what support we can, and we'll try and showcase trainees' work through getting them to present at conferences, both in London and at opportunities like this, and through the Leadership Fellows. And that's it. That's my Twitter handle, so if anyone wants to tweet me directly, then please do.
Thanks very much indeed. Now the truth comes out. The assessment tail wags the dog. Put the quality improvements as part of their finals. They have to do it, final assessments. Thanks so much, Kat.